Welcome everybody. My name is Erica Conybe. We're very excited to have you all join for our second webinar. So just a outline for today's webinar. The topic is the rehabilitation of the distal radius fracture. We're going to go through 20 minutes of initial management and then speak on strengthening conditioning. And there will be time for question and discussion at the end. If you have any other questions, please contact us. A lot of you may have already been corresponding via our info email address with me, but we will get back to you as soon as possible. Okay, I'm going to stop sharing my screen, and I'm just going to introduce our speakers, and then they will start with their presentations. So thank you, Adele and Leanne, for joining us and for being willing to share. So Leanne Chazen completed her BSc degree in occupational therapy at the University of the Witwatersrand in 2006. In 2013, she completed her master's in neuroscience, and she also completed her diploma in hand therapy in 2015. After completing her community service year in Johannesburg, she moved into private practice, and she has been running her own practice since 2012. Leanne is a mom of 3 and an avid road runner and is involved in youth development. Adele Viljoen. Adele qualified with her OT degree from Stellenbosch University in 2004. Adele took her community service post in Zanin, which is in Limpopo, and she was very grateful to rotate between the wards and get a variety of experience. Following this, Adele worked in a private psychiatric clinic for 3 years, where she worked with adults and teenagers on an individual basis and in groups. Then she worked in Tygerberg Hospital's work assessment unit, again laying a vital foundation for her hand therapy practice. And in 2010, Adele started her own practice, which focused on upper limb therapy, and she continues to run that. She is a mom of 2 and passionate about helping people. So thank you both for your time this evening. Over to you.
Can you hear me?
Yes.
Hi. Can you guys see me? Okay, thanks. Hi. Thank you so much, Erica and your team, for this open hand initiative. It's really amazing. I wished it was there when I started my practice 14 years ago. All those evenings paging through textbooks, planning the next session. So yeah, it's really a privilege, and yeah, thanks for everyone attending. Today, what Leanne and I are going to try to teach you is not to specifically focus on a set protocol, to say this is the set protocol. We're going to try to teach you the tools, how to look at your patient, assess the situation, assess the symptoms, assess what you see, and then decide on the appropriate action for whatever the phase of healing is. So we're going to have a look at anatomy. We can have a look at typical problems expected. We're going to have a look at different therapy ideas. There's lots of practical videos and pictures. So hopefully when you go out after this, you'll be able to identify the priority problems with your patient and know how to treat them. Okay, thanks, Leanne. So the first slide we see is let's just quickly look at the anatomy of the hand. We know we've got a patient with a distal radius fracture. So immediately our minds drift towards the inside of the hand to the fracture, and we think of the fracture. Now, if we want to look at mobility of the wrists, ultimately, if we get a patient referred, we want a functional patient, an independent patient. In order to do that, we need a mobile hand and forearm and wrist, and we need good grip strength. But if we only focus on mobility of the bony structures inside, we might miss some of the overlying layers. So looking at the hand from the outside inwards, yes, we're aiming towards the radius, but the first layer we see on that picture is the skin. Skin, as we know, is stretchy, but when skin is being immobilized, it's not as mobile as before. So we'll get to treatment later. But the skin is something that gets tight under a cast. Underneath the skin, we have the fascia, as you can see there also, that's a really tight structure that can also limit movements between the muscle layers and the skin. Thanks. Yeah. You'll see underneath the skin, I just included this slide to show you the very, very delicate lymphatic system, which is so close to the surface of the skin, just to remember, when we work with patients, even something like a strap or the way we hold or massage or splints can influence the edema. So just to have a visual of how delicate and superficial the lymphatic system actually is. Then next, we get the slide of the tendons and the muscles in the forearm. So as we know, the flexor tendons are long. The tendons in themselves are inflexible structures. But if we think of the muscles, they can go into a spasm and they can contract, which will limit the wrist movement. I like to use the analogy of a truck. If I drive on the highway and I see this truck in front of me, if the straps at the side of the truck are tight, that move is not going to shift. Whereas when the straps are loose, the load will shift. In the same way, when the flexor and extensor tendons are in a spasm and tight, you'll get limited wrist movement, and you need to work on these muscles first before you'll get wrist mobility. So that's just one to remember. Then the ligaments in the wrist, they also contract. The ligaments as well as the capsule. We also need to address those in therapy. And then the next couple of slides is just to quickly mention that there are other important structures in the wrist as well. The first one, the distal radial ulnar joints. The next one, the TFCC ligaments at the side of the wrist, and also the SL ligaments. We're not going to go into detail with them now because we don't have time, but this is to park on the back of your mind, just to remember when you're in the later phases of rehab and you see, sure, why is this pain, there's like a funny clicking or clunking. Why is this pain not going away? Why is this grip strength not improving? Why are we reaching a plateau? Then you go back to these notes and you look at these three, you look at these three ligament structures, you test them. This is, for example, a very simple TFCC test, a press test, where the patient presses down on the chair, try to lift themselves up. The test is positive if there's an ulnar-sided pain in the wrist, in which case you refer to orthopedic surgeon for further investigation. So this is really just something in the back of your mind. When something doesn't work in therapy, we try something else. We don't continue to do the same thing. We need to think a little bit out of the box. The next slide is about the radius and ulnar. Just for you to have a visual that we are focused on the wrist, on the distal radius fracture, but remember that the radius and ulnar work together. So the two of them work together to provide a supination and pronation. Your ulnar being on the pinky side of your hand, that's your elbow bone, you can feel at the back, your cranium. And the ulnar in the wrist is not very significant. The radius in the wrist is the large bone that rotates with the scaphoid and lunate mostly, and that is the one that we want to get mobile after you've had this radius fracture. And there you can see the supinators and pronators also moving the forearm in rotation. Okay, I need to have a look at my time because there's always a lot to say. We moved on from there. Then on the next slide, we see there's different types of distal radius fractures. Fractures can happen in multiple ways. But if a doctor says to you, you've got a Colles fracture or a Smith fracture, the biggest difference is with a Colles fracture is patients falling forward. Usually when a foot slips and you block behind you or you fall forward at a speed, you'll get an extension fracture. Whereas if you hold your wrist in a flexed position and then fall on the wrist, it's called a Smith fracture. So the displacement is just slightly, it's in the different opposite direction. So that's just the difference between those two. And then the next slide, this is actually the one that's very significant to determine your prognosis. If you have an intra-articular fracture, the two ones on the right hand of the screen, you will likely have less movement in the end after rehab. But if it's an extra-articular fracture and the joint is completely congruent and healthy, then the chances are good that you'll get very good wrist mobility back after the incident. So just important when you do goal setting as well to notice, was it a comminuted fracture? Was it an intra-articular fracture? Because that will determine the prognosis and the outcome as well. So next, just remember the mechanism of injuries. When you do your initial assessment of the patient, there's a difference between, being hit with a metal bar on your hand and having a clean fracture extra-articular than, for example, a patient that falls down the stairs and grabs onto the railings and twists the wrist in the same while and then falls on top of it and then breaks it. It's always important when you do your initial assessment to find out how did you get injured, because you're keeping those ligaments in the back of your mind, what you might test later, what might be associated injuries or what might delay healing. Okay.
Thanks, Adele. So the other thing that's important to consider is basically the phases of tissue healing. So firstly, looking at the bone healing. So usually it's this, we hear this big 6-week magic marker, but it's actually the first 2 to 3 weeks that are most important, because by 2 to 3 weeks, the bone fragments start to become sticky. And then they're able to actually hold together. If there's too much movement in those initial 2 weeks, then that keeps on disrupting that healing process, and then you don't get the bones becoming sticky. But if the patient is well immobilized for those first 2 to 3 weeks, then it's sufficient to be able to then start with movement. So controlled movements. So remember, movement doesn't always mean weight bearing or lifting things, but a controlled movement of a joint can start quite early on. But as long as the patient understands that what they should be doing, that they should just be moving and not lifting, for example. Usually by 6 weeks. So again, depending on when you're receiving your patient, and also depending on whether or not it's a post-operative patient or if it's a conservative distal radius fracture, you need to consider where the patient is. But usually by 6 weeks, you can usually palpate over the fracture site, and you'll be able to palpate the callus formation. If it's no longer painful, then you know you can generally move forward with confidence, and you want to give the patient a lot of confidence because you don't want the patient afraid to move. If you are looking for definite clarity, you will probably need to then communicate with your surgeon. But if you don't have access to a surgeon or to a doctor or to x-rays, then you can also just palpate around that site to give you the confidence to move forward. The other thing to consider is the wound healing phase. So remember, the first thing when the patient sits down in front of you is you want to gauge, where am I from the injury? How many weeks post-injury? How many days post-injury? Now, the wound healing phase, remember, the first 10 days is your initial inflammatory wound healing phase. This is where it's normal for the patient to have swelling. It's normal for the patient to have pain. And you're not going to aggravate that by trying to now move this patient aggressively. You want the patient to rest. But as you head into the 2 weeks, you're heading into that fibroplasia, that proliferation, all the new cells are starting to form. And this is when you have influence on the tissues. You want to move the tissues. You want to limit the scar maturation phase and the patient being stuck in that late phase, because that's when it becomes a lot more difficult to move the tissues. So just like what Adele was saying, if there's multiple structures injured, then you need to consider what is the healing time that's needed for those multiple structures. Whoopsie, sorry. So then you'll need to obviously understand the extent of the injury. So for example, if it was a ligament sprain that they had with the fracture, then you might need to actually unpack that a little bit further. Was it a grade 1, 2, or 3? Because each one is going to need a certain amount of protection. It doesn't necessarily mean that you cannot move that structure at all. It just means you're going to have to look at what is the soft tissue structure that is painful with a certain movement, and you're going to have to avoid that particular movement. So it will take a little bit more research and on your part to read up a little bit more about that particular tissue that's been injured. So generally we look at the early phase and then the late phase. So the early phase, we would say, is within the initial 6 weeks. You're focusing a lot on education. You're generally mobilizing the fracture. It's a lot of pain and edema management. You want to mobilize the unaffected joints, but if you can, depending on stability, remember the moment a doctor puts in a K-wire or a plate, it does make the fracture more stable, which means you can move a lot earlier. So that is one of the benefits of having fixation in the joint. And then you also want to consider the skin mobilization. So there's a lot of mobilizing that happens in the early phases as well. For your assessment, you're generally focusing more on your impairments. And often you're adapting your ADLs, because if you don't want them to move the wrist, then they're going to have to adapt by moving their shoulder. And you want to help them to find ways to be able to do their ADLs. And then you're also going to be making a lot of contact with employers and families. In the later phases, you're going to focus weaning off of the splint. You want to get rid of that splint so the patient isn't dependent on it. You want to really go into a lot of movement, progressive mobilization, passive range of motion, strengthening, conditioning, work hardening, and then the scar management. And then your focus is also on your ADLs. You really, you don't want to get too stuck and hung up on range of motion, moving 2 degrees each session. You really want to focus in the later stages. Can the patient actually do what they want to do? Okay, so when it comes to assessments, we've broken it up into body structure, function, impairments, and then limitations. So Adele will present the limitations. So for body structure, we're going to just quickly cover wounds, pain, edema, sensation, range of motion, scarring, and grip strength. So when assessing, I don't know what happened to my heading. For wounds, basically different hospitals might have different protocols. So you want to just make sure that that you're familiar with the protocol at your practice. You want to evaluate the wound. Is it a surgical scar, or is it a laceration, or is it soft tissue damage? The wound that you're dealing with, because each one is going to come with its own parameters. A soft tissue injury comes with a lot more complications because there's a lot more extensive damage, which means there's a lot more scarring. And then you want to evaluate the actual patient. Do they have the ability to do their own dressing? So do they have insight? Are they able to identify the signs of infection? Will they be able to contact you if there's a problem? Is there a WhatsApp number that they can send a picture if they're not sure about something? And then when would it be appropriate for them to return to work? Because if they are working in a dirty environment, then you might not want to have that until the wound is closed. Okay, when it comes to pain evaluation, I think the most important thing for you to remember is that you need to understand why they feel the way they do about their hand and why they feel they're getting pain. So in other words, what are their fears around movement or using the hand, or what are their beliefs about what they're doing? And I think, once you understand that, then you're able to address those fears and those beliefs. They might say, oh, but when I'm moving, it feels like this plate is just pulling apart, and then you can address those fears because, on your side, you'll know, okay, it's stable. It's safe for us to move. It's about creating this environment where the patient feels safe. What's very helpful with pain is to use a scale and to use the same scale every time you see the patient. And then using that scale, so have them rate their pain out of 10 at rest, with movement, with palpation, and then with specific tasks. It helps you also to understand how the patient is moving along the journey in terms of managing their pain. Always gain their trust. So respect that they are experiencing pain and don't try and force them to that. And then also in terms of their personality, certain people really push themselves really hard. Other people struggle to push themselves. So you also want to understand, are you dealing with someone who really pushes themselves, and maybe you actually need to overprotect this person to protect them from themselves, or you actually maybe need to give the person a bit more encouragement. Okay, so the next impairment is edema. Now, edema, you don't have to spend hours measuring edema, but it is important that you have some type of measurement. So even if it is just a circumferential measurement, around the metacarpal heads or around the wrist, or take a picture and compare the two hands, or just have, where you circle mild, moderate, or severe. The thing with edema is that edema has a big impact on the movement patterns. And I just want to quickly play you these videos. So the first one, what you'll see is that this patient has now been, immobilized. And as she's trying to mobilize, the edema is really restricting her mobility. So she's starting to adopt these very abnormal movement patterns. And it's making it very difficult for her to do what she needs to do. So you can see, again, you're not going to have edema in isolation as a problem in isolation. Always you're going to have range of motion, pain being problems, and you're going to be addressing those problems at the same time. This particular patient, you can also see a lot of edema over the back of the hand. The fingers are really like little sausages, and this is making it difficult for her to flex her fingers. So she's looking for strength now from her wrist flexors. So you can see as she's picking up, she's flexing her wrist, but actually that's counterproductive to what she needs, because she's losing that lovely tenodesis, the strength she would get in her fingers as she extends her wrist. So in her case, you really want to encourage her to extend her wrist and flex her fingers at the same time. So you're going to be working a lot on the movement patterns to try and help that. Okay, when assessing sensation, so these pictures are courtesy of the Virtual Hand Fellowship, and I would strongly recommend anyone who's interested in hands to follow them on LinkedIn, because they post such wonderful material. And so these were some that I took a screenshot of recently, just showing a beautiful representation of the ulnar nerve, the sensory and motor branches, and then the median nerve. So if you have a patient that has an injury that's near a nerve, you're already anticipating what the patient's going to be experiencing if there are some sensory nerve, if there is going to be some sensory nerve fallout. So draw a picture of their hand. You don't have to have access to monofilaments. You can use simple objects. You can use a pen, a paper clip, a soft makeup brush. And then generally the instruction, what you're going to be doing is you're going to be taking their vision away, and you just put up a piece of paper, and then the instruction would be, if you feel something, say yes. And then you will test the different areas. You can also do some fresh air tests, because patients always want to please you and they always want to say, yes, 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 I can feel. But then you can actually test whether or not they are feeling and whether or not they're responding to what you actually are testing. It might not be the first test that you'll do in your initial session, but it's definitely something that through the process of your assessment that you're going to evaluate. Okay, range of motion. Again, another example of where range of motion and edema, work very, very closely together. So you have to consider also, when you're measuring range of motion, consider the pain, the swelling, the anxiety. These things are all going to influence your readings. But it is important that you've got a good, thorough initial assessment. If you only have very limited time, you want to hone in on what is most important within the session. So because we are talking about distal radius fractures, generally, you might only be measuring wrist flexion extension, and then you'll come back a bit later, maybe on the follow-up session, and measure radial and ulnar deviation. But your key movements are going to be your wrist flexion extension and then your forearm pronation supination. In this particular case, obviously, he's also got a lot of MCPJ, stiffness, or flexion to palm stiffness. So that would also be something that I would measure. Okay, so just in terms of my preferred technique for measuring range of motion, this is how I would do it. There are different techniques, but it's important that within your department that everyone is using the same technique, because if I see your patient today and someone else sees my patient in 2 weeks' time, and they say, oh, you're doing so well, you've progressed from 30 degrees to 50 degrees, but actually you're using different techniques, you can't really rely on that information. So my preferred technique would be the axis of the goniometer going right through the wrist joint, and then the stable arm being along the ulnar border, and then the movement arm would be along the line of the fifth metacarpal. I don't use the back of the hand because often that is influenced by swelling, so I'd rather use this imaginary line that goes up through the metacarpal. Again, as long as it's just consistent across the department and you're using the same technique each time. Measuring forearm mobility is also quite a challenge, and it's definitely a two-handed job. Again, this is my preferred technique. There might be others that you find works better, and you can use that as well. So what I'm doing here is I'm facing the patient head on, and the axis is going through the elbow joint. Then the stable arm is in line with the humerus, and then I'm holding a pen to try and help me gauge. That will be the movement arm to try and help me gauge that angle. But you don't also have to get too caught up in those, or if you don't even have a goniometer, there are some other things that you can do. So for the fingers and thumb, you can use your kapanji. That's something that I use very regularly, just about every day with almost every patient. So this is just an example of, this is kapanji, just showing you where to measure. Again, print it out and put it up in your department so everyone knows what the different numbers represent. You can also use a ruler, so measuring from the tip of the index finger to the tip of the thumb for thumb extension. You can also use a ruler to measure flexion to palm, so how far they're away from the distal palmar crease or even just the palm. You can even draw line pictures of the hand on paper. So if the patient lays their hand flat on the table, you draw a line on the back of the hand, and then you get them to extend their wrist and see if they can move to a particular line. Now, the wonderful thing is, because we're OTs as well, and we can focus on function, we can have also functional evaluation. So for all these movements, forearm and wrist movements, you can also look at these kind of markers. So if you try now yourselves, if you touch your hand into your armpit, you will see you're flexing your wrist quite a lot. If you hold a bowl, imagine you're holding a bowl, holding a tray, you are completely supinating your hand. If you turn a key, You'll see how you're engaging all your thumb muscles. Eating and drinking, you'll be able to see pronation, supination, mid position on the forearm. Your hand to your bra strap also incorporates a lot of wrist flexion. Patients needing to wipe, also bringing in a lot of forearm movement. Working at a tabletop, pronated position, working while typing, also some wrist extension, and then hands in the pocket is also quite a nice one for wrist extension as well. So you can use functional markers as well for your range of motion. Okay, so scarring. So again, is it a post-surgical scar versus a laceration or soft tissue? What you want to look at is the scar sensitive? Is it adherent to the structures underneath? Like Adele was showing you all those anatomical structures. Is there banding or contracture where it crosses a web space or a crease line? And then compare it to the other scars on the patient's body. Is it a normal scar for the patient, or is it abnormal? And is it functionally limiting? And then lastly, just grip strength. Usually in the later phases, patients absolutely love doing a grip strength measurement. And these little Camry dynamometers are really quite affordable. I would definitely encourage you to get one for your department if you don't have one. It gives you a wonderful baseline. I would usually do 3 measurements on each hand to get an average, and then only monthly measurements, because you're not going to see the progress generally in less than a month. And consider the occupational demands. You know, you're not trying to get the patient up to 50 kilograms of force if they're only having to do administrative work and they don't gym at all. So you can use norms to help guide you. Again, it's just a guide, because you're not going to expect too much from a patient who is sedentary versus someone who's a manual worker.
Thanks, Leanne. Yeah. If it's okay, I just want to add one thing with the range of movement. You know, there are so many measurements in textbooks where they say this is the norm, and you'll see it's often between 60 and 90 degrees or whatever it might be. It's a good idea always just to measure the contralateral hand as well, just to use that as a norm, because some people are more mobile, hypermobile or not, and that's a good guide as to where you're aiming with that specific patient's mobility. Okay, so I'm going to chat a bit about the activity limitations. Patients often want to know, you know, what can I do? What can't I do? And for the life of me, I don't know why this happens, but they always come back to say they tried to pick up the kettle and then something happened. It's always the kettle, and they always want to try to make a cup of coffee. So I said, guys, please don't start with picking up the kettle. It's important to know the patients, it's difficult for them to gauge what they can and can't do. As soon as they feel they don't have pain, they think they are independent, and they don't realize that there's limited grip strength and all these things. So same with going back to work. Patients often wonder, and employers wonder, you know, what can and can't you do? And there's a lot of confusion as to kilograms. Sometimes the employers want a kilogram, or how many kilos can he pick up? But there's a big difference, you know, if you can sometimes pull a pallet jack with 200 kilos on there, and it's going to do nothing to your wrist, but you can't wring out a cloth, because that is going to injure your wrist and hurt it. So we always guide patients to say, make sure that it's going to be pain-free and safe. You know, if you're holding a grinder, even though it weighs 2 kilos, it's not safe to work with a grinder if you're still healing. And if you do anything as repetitive or that causes pain or edema, this is the way the hand talks back to you. The hand will tell you, I'm feeling sore, I'm feeling swollen, that's too much. Typically at 6 weeks, we can look at 2 kilograms for a rough guideline, managing 2 kilograms if it is safe and pain-free. There's a whole lot of assessments that you can do, like the quick dash questionnaire, writing MODAPs, typing speed tests, lifting evaluations. Remember also when lifting, for example, if patients pick up a crate, you know, when you're down at the floor, holding onto the crate, your wrist is in neutral, but as you extend towards a height, then the wrist moves into ulnar deviation. So that dynamic force can cause a lot of tension on the wrist. Just be careful. Start with light weights when checking, and make sure the patient can, you know, if they can squeeze 2 kilograms with the JMR, doesn't mean, or maybe 20 kilograms, it doesn't mean they can necessarily pick up 20 kilograms, because the dynamics of the dynamic movement with the wrist. So some of the formal tests we can do are these that are listed. And also I like to ask my patients at the first session, go home and write a list of all the things that you cannot do. that you would like to do. And they come back with a long list. And then you can chat about adaptations, how can you wring out a face cloth with one hand? What can you do, with, turning a key in the door? But they've got to come with a list for these specific lifestyle goals. As you can see, these patients, the guy on the left will do whatever it takes to get back on his cycle. And it's typically cyclists, Hayley Ann. At the first session, they'll just, when can I get back on my bike? Cyclists are notoriously bad.
Yes.
You can encourage your patients to continue exercising in a safe manner and help them, to get ideas, what exercises they can do without risking injuring their wrists. There's a lot they can do. And as OTs, we've got the privilege to look at activities. And like Anne also mentioned, that trust with the patient is so important. We don't always have to agree with everything the patient says, but if we hear them and try to make a plan together with them to reach their goals while they're healing, there's a very good therapeutic relationship, and they're much more willing to then comply with the other suggestions that we make as well. So yeah, the guy on the left wants to cycle, the lady possibly just wants to do basic self-care, play bingo, have a cup of tea. But ask her, because you might be surprised at what she might want to do. Okay, so just remember the client-centered approach.
Okay, so in terms of treatment, the important thing here is to identify what is it that you're treating. So I think being purposeful, are you treating the impairment? Are you treating the limitation? And not just choosing, if you are doing a particular activity, if you want to do an activity to improve wrist extension, make sure that the activity demands wrist extension. If you're doing something to improve pinch, make sure the activity demands that. So we have included a treatment protocol, but we're literally going to skim over this. We're actually not even going to go into it in detail, because it is better to rather focus on the impairment and the limitations and not the protocols. The protocol is really a guide to kind of say, in this period of time, this is what you should be doing. However, if a patient of yours at 3 weeks post-surgery is experiencing significant limitations in range of motion, you might introduce passive range of motion, because they're so weak and they don't have the strength to overcome that stiffness and that swelling. You're going to bring in some gentle passive range of motion, because if you don't and you only wait for 6 weeks, then you're going to end up losing that movement. So rather focus on what the impairment is, and then just use the treatment protocols as your guide. Okay, so when it comes to choosing a splint, just 1 or 2 tips I wanted to give you. Please watch the heat of your frying pan. Don't turn the frying pan up to maximum heat. That's what therapists do, because they think it's going to heat up the water quicker. Start at level 1 or 2 and just leave it there. If you have your water bubbling and then you put your splinting material into the water while it's bubbling, you're going to end up losing that lovely moldability. Well, it's going to actually end up making it a lot more sticky, your material, and it just has to go in until the material becomes soft. You don't have to leave it in there. I think one of the biggest mistakes that a young therapist will do is that they'll get going with the patient, they'll put the material into the water, and then they'll step away, and then before you know it, the material's been sitting in the water for a minute under this bubbling hot water, and then when you bring it out, you end up really losing a lot of that strength in the material. So that's just some little tips. Okay, so in terms of choosing your splint, you've got to understand, what is the purpose of your splint? Are you splinting to stabilize? Are you splinting to try and gain range of motion? What is it that you're needing to do? So in this particular case, this is a bivalve splint, and this one as well. So that's really to stabilize, to fix, to immobilize a wrist so that there's no movement. So we talk about a snug fit. That means that particular doctor doesn't want any movement to allow any of those fragments to move around, in which case the patient might have to come back on a weekly basis for remolding to make sure that it is a snug fit. Generally, if it's a post-operative splint and there's an RF inside and we know that it's nice and stable, we can go for a volar forearm-based wrist extension splint. And this particular splint this is a derotation splint. So if there are some TFCC, some involvement of the TFCC structures, and specifically you don't want pronation, supination, then you might need to do a splint like this, or sometimes you even include the full elbow, again, depending on what the surgeon is requesting, or depending on the location. But in our case, distal radius fractures, generally it would just be if there's some TFCC involvement. So there were just some pointers that I wanted to talk about in terms of splint fabrication. So whether you choose to do an open thumb or to do a circle, the principles are exactly the same. You want to make sure that the patient has full finger flexion. So you want to make sure that your splint comes just proximal to the distal palmar crease, and you need to be able to see your crease. So you want to make sure that when you're drawing your pattern, that you make sure that you're using that point. You also sometimes here in the web space, this can sometimes be a problem, area in terms of pressure. Also here at the base of the thumb. So you want to make sure that you've cleared enough space at the base of your thumb, but you don't want to make sure that it's too much, because then you get a thin splint here that's not strong enough. So you want to make sure it's wide enough. I usually check that the patient can oppose only to the index and middle finger, even just usually to the index finger. The moment the patient is opposing in their splint to the ring and the small fingers, you're going to have your splint is going to be too narrow to give you any strength. And then also just a problem area sometimes is your ulnar head that can be quite prominent there. You want to make sure that you've got at least 2/3 of your forearm to give your splint enough strength to be able to apply the force of your splint, which is going to be here in the palm, to lift the wrist. So you need at least 2/3 on your forearm. And you want to account also for the shape of the arm. So make sure that it follows the contour. Don't just have a straight line going down, because then you're going to be too narrow around the forearm. And again, a patient that is quite a large patient with lots of muscles here, then you're going to take it even wider, because you want to make sure that that curve, because the curve is what gives your splint your strength, you want to make sure that that curve follows that contour of the hand, of the arm. And then when you're telling them what to do with their splint, okay, the patient is not going to remember all your instructions. So please write it down for them. So either you can write it, take a picture, take a video on their phone, send a WhatsApp, send an email, make sure there's a family member present, make sure you're putting things in place so that they know exactly when they must wear their splint, when are they allowed to take it off, what exercises they have to do when taking it off. Adele, over to you.
I was talking to myself. I was on mute. Thanks.
Oh.
I was talking, but it was just to myself. So tendon glides are lovely exercises. They're one of the first ones we can give patients. Patients like saying, yes, I am mobilizing my fingers, and they typically do something like this, which is just slight MP flexion. We're not really getting anything decent done. So it's nice to break it down to them. And with these tendon gliding exercises, make yourself a pamphlet that you can hand out to patients. If you don't have access to a copy machine, make one, laminate it, or keep it with you, put in a flip file, let them take a picture of that so they've got it with them. Because they've got an information overload in the session. I think it's also something that we need to be aware of. We speak a lot in therapy also to the patients to make sure that they actually grasp what we're saying, or give them an image to take home. So with this tendon glides, as we can see there, they're very simple, but we get full IP. Okay, in this position, we get full MP flexion, full IP extension. Now we get the opposite, full flexion, full extension. Over here, we've got a lovely stretch of the flexors. And when we do the composite flexion, we get a nice stretch of all the extensor muscles. Remember the last one, the fist, is please just note to the patients, it's not a power fist. It's just a positioning fist. So just basically going through the exercises with them like that. And they'll get that as a nice home exercise program with the initial session. The thumb, I see I didn't include it in this slide. Remember just that the position of the thumb is right aligned with the distal radius. So this one is going to be more tender to move. The one that we should still include is your inter-ossei muscles, just to abduct and adduct to make sure that they remain nice and mobile and stretched out, the intrinsic hand muscles. And we can include the thumb also in some movement, but very gentle with the thumb. You can do extension or abduction, flexion. But as I say, be careful because there's going to be more pain over there. Edema management is important, likely, and also mentioned, we want to get the edema drained as quick as possible. Initial phases of edema can be managed by elevation with fist pumps. So we like telling the patients to do fist pumps like this. They can do it every hour, 20 times an hour, and that activates the lymphatic system to literally pull the water out of the hand. So even if they just elevate and do these fist pumps hourly, 20, it will minimize the edema significantly. Chibi grip that can be carefully put on is also a good idea in the initial phases. And later you'll see that the edema becomes a bit more thick. And you'll see it's more, you can actually see little indents in the hand when you press down on it. Then we need some more compression and massage. So what we can do, I don't have a spatula with me, but a tongue depressor, you can gently start mobilizing the skin and the edema in a backward direction. You can actually start at the arm and move, all the way up and scratch on the hand, or you can do manual edema massage. Again, we start at the back, we drain the edema, 2 minutes for a hand-sized area, so 2, 4, 6, 8 minutes, and then we can stroke down the edema in a position of innovation. This is something nice that they can do as well, at home as well. How hard to massage? We always say, it's like stroking a cat or stroking a dog. So it's like a deep stroke on the hand. That's good for the edema. When we get to the phase of this picture where we've got pitting edema, and I suspect that's because of the laceration. You see the laceration over the wrist and the hand, which blocks the pathways. This guy needs help. So we need perhaps a pressure garment. We can make a gauntlet, or you can take a tubey grip that you fold over double over the hand and then single over the arm. And then underneath that tubey grip, it works really well for this pitting edema, is if you can insert a little sock inside. So you can take a piece of stockinette or tubey grip this size, and inside you insert all sorts of different textures. So you cut up pieces of string, sponge, neoprene, all offcuts, not splinting material, but all soft and firm offcuts of materials. Put it inside the sock, sew it closed, and then tuck that sock underneath. And because of the difference in pressure that the different objects give, you will get a flow of the lymph, and that gives a very good, that gets that very pitting edema to move away quickly. But the sooner we can get the edema away, the better. So next, there's some video ideas of activities. So this is a nice one to start with the initial phases. Gentle wrist extension flexion. You'll see on the table, there's 2 colored pens. That's a nice visual for patients to remember. And then ulnar and radial deviation. And this, we like to call the royal wave. So supination, pronation, but they think of royalty when they do this one. Then the next one is when we start, typically perhaps at 3-4 weeks, depending on healing and pain, with a very, very light weight, maybe 4 weeks rather, with a wrist flexion over the table edge. You don't need a lot of expensive equipment, and they can do this at home. We always like to do activity ideas in the session that the patients can duplicate at home. No point in having fancy equipment, and then what do they do at home? And then the last one, this is the dart throwing motion. So you can Google a bit about the dart throwing motion. The wrist can move in many different directions, but the specific line we use to throw a dart is the same line we use to hit with a hammer. It's the same line we use to cut a slice of bread or cheese. It's the same line we use to pull up our pants. So this line is an important one to strengthen to prevent injuries when they're returning to their activities. And then there's thanks. And this is another slide just to show a different idea with resistance. So this is a very nice activity also to get the left and the right hand to work together again. We often forget, we neglect the injured hand, and we need to use them functionally together. So this is a very nice idea to get your wrist flexion, extension. And you can add different weights. So at the bottom, you have a bar. You can even add a bottle filled with sand at the bottom of the first slide. Second one, pronation, supination. Also a nice functional activity, which also gives them, there we go. And that's lovely over the shoulders as well. Just to get more of the composite movement. So we move away from simply isolated movement to the more complex combined movements to enable them to function. This is also very good for patients' confidence. As soon as they see they can do this in therapy, they're like, oh, if I can do this in the therapy room, I should be able to do X, Y, Z at home or at work. Yeah, not neglecting the resistance training in the fingers. So pincer grasp, resistance training, combined again with supination, also for functional tasks. Leanne, I think this one we said you're going to chat about, or do you?
Oh, sorry. Yes. Yeah.
No,
So again, just incorporating just a range. I mean, very low cost tools. These little rings were made with offcuts of splinting material. So just again to pronation, supination, and you can also gauge how much the patient is able to do, and you can adapt it obviously for those that aren't able to do too much. And then a bowl is also a nice way, and then you can also progress to a tray. A tray would be more demanding on the hand, but a bowl, and usually getting them to try and move the bowl into supination. And then even just some simple little discs with a container that has a little key slot. So you can have them pick it up, and then just depending, you can have the patient doing it completely independently while you then busy writing your notes and getting your notes done. You just make sure that they set up while you're watching, and then you can quickly watch them to make sure that they're doing it correctly as you're busy recording your notes.
Adele and Leanne, I'm just giving you 5 more minutes to wrap up, if that's okay.
Sure. Adele, do you want to then just jump through these ones?
Yes. Okay, let me just... Okay, so that first one, also resisted flexion extension. You can fabricate this with a paper towel roller on a ruler. So if you get your Velcro strips, the one around the paper towel, the other one on a ruler, the patient can get an assistive device to take home to strengthen supination, pronation, flexion, and extension. The middle one is a very nice activity. If you picture a clock on the table, 12, 3, 6, 9, you can work in all the different directions, and you can ask the patient what line is painful, and they'll say, oh, you know what, it's the 1-7 line, or it's the 10-4 line, and you can then make a further assessment based on that, what is maybe sore, what's causing the pain there, or then strengthen those lines. Last one, also for stability control, having a tennis racket or a shovel. I don't know what's available. Maybe everybody has tennis rackets, but it's nice if you have one there, and a ball, different size and weights of balls, just to have them move it in a circular motion. And then upgrade that. This is, the broom. You can resist your pronation and supination with that, but you can actually also do, on the left hand, the first video, the dart throwing motion with a broom. For people that need intense strengthening, like construction workers, people that are hitting a hammer. So pronation, supination you can do with that, and also your dart throwing motion. Then there's one last thing. There's now actually quite a few these protocol that we put down for you. We're definitely not going to go through it now because we don't have time, but that also wasn't the plan from the start. Go read through it at home and make your own notes on that. This is just a rough guideline. What to do in your initial session, what to do week 2 to 4, what to do week 4 to 6, and week 6 to 8. It's not set in stone, because when you do your assessment and you see the pain or edema is different than what you expected, you're going to address that first. Last thing I just quickly want to mention in 2 minutes, the risk factors for a poor functional outcome. When we treat a patient with a distal radius fracture, remember that we're not just treating the injury, we're treating this whole patient. And if there's something in the patient that makes them non-compliant, perhaps fear, perhaps culture, then it has to be addressed. Otherwise, you're not going to get success in your treatment. So, for example, the severity of the fracture is obviously making a big difference if there's a late referral to therapy. So this is something to discuss with the doctors at your clinic or hospital to train them. Doctors sometimes think that when they refer to therapy, they expect us to gym the patients and work, and they say, oh, the patient's not ready for therapy. But go talk to them, tell them, doctor, we actually work from day one to manage the edema, to get better wound healing, to, all these things. Explain to them that when you make a cast, a thermoplastic cast, instead of plaster of Paris, you can do better wound care. You can manage the wounds and all these things better. So educate the doctors on that. Remember, sometimes patients arrive with a different diagnosis. They might arrive with a diagnosis of depression already. So they might, we're not the psychologists, but we might have to consider our goal setting, maybe some smaller steps, maybe a bit more motivation for the patient. And the last thing I just want to also remind you is sometimes be careful. Sometimes patients might develop a bit of a dependency on the therapist. They might at the end of therapy not be ready to finish off with therapy or to be discharged. And we can typically see when you tell the patients, okay, you're doing so good, next week we'll probably do the final. And the next week they come in, there's more pain, they can't work, and you can just see they're not ready to be discharged. They're not ready to let go of the support. So to be aware of that as well, and then to motivate them and help them with goal settings, why they would actually why they should want to finish with therapy and become excited about returning back to their normal and previous ADLs. Yeah, but maybe you can read through this again later. It's all written down there. We just don't have time to discuss everything now.
Okay, so just some humor to end off with. We did actually list down some of the Q&A questions that came in the initial presentation, but maybe it would be better to open the floor up to questions. So
yeah, thanks so
that's it.
much, Adele and Leanne. That was a really amazing presentation. I loved all the practical. We can maybe just answer a couple of questions. So one that came up in the chat is so for those therapists who are working in government hospitals and conditions get covered with plaster of Paris, how would you recommend the plaster of Paris be applied to for optimum healing to the forearm?
Okay, so I think what's important, the mistakes that we often see with the plaster of Paris is, and this is about educating the doctors, we often see that that it's applied to, over the MCP joints. So basically the doctors just need to learn, it's not on that line, it's on the distal palmar crease. So maybe that's something you can chat with your doctors to free the MP joints. And often we also see the cast, it's ideal to place it in about 20-30 degrees of extension in the wrists. We often, when a patient has had an RF, see them lying in theatre and they arrive at the first therapy session with ulnar deviation. And I'm not sure, but I often think it's because somebody holds the hand in theatre while somebody else puts on the dressing and you get that dip of the ulnar deviation. So those things you can maybe just address with the doctors and recommend to them why they need to do splinting in a certain way. Anything else, Leanne, that you can add there?
No, I would agree with you. I would say if you also, as a therapist, you only have access to POP, and you now, you've got a patient and there's a diagnosis of a wrist fracture, I would advise to just use the POP as a slab, and then try and just get that nice gentle wrist extended position, and then apply that with, so you're using a slab piece that gets hard, and then they can remove that to then do some light exercises, probably from about 4 weeks, and then reapply in between the exercises. So yeah, I mean, it's quite nice and versatile at least.
You could also, if needed, do a pop volar distal and cut it and fasten that with Velcro. So we've seen that as well with patients that really have got very limited funds, medical aid patients, but they need a removable splint. So, we split it, we add Velcro. It's not ideal, but, it saves them money and it's functional.
Definitely.
Thanks. There's another question in the chat about using dynamic or kinesio tape for weaning off of a splint or additional support. Do you use that?
So I think just when it comes to the kinesio tape, I think it's important to understand, like, why are you using the kinesio tape? So I think as with any technique that you're going to use, what is the purpose of this? Am I using it to achieve stability? A kinesio tape is not going to give you stability. I think especially when you're looking at splint weaning, do you need a rigid stability, or do you need, maybe something like, a neoprene that is just a buffer between having a splint on and having nothing on, but I think kinesio tape, if you're using it to address the skin and to address edema and to, from that perspective. So I think it's just important to understand, why am I using the tape? Yeah, Adele, I don't know if you have anything on your side.
Yeah, and then especially to notice, I know, I completely agree, and then to notice where it, if a patient tends to tell, on the outside of my hand, it stays sore there, stick kinesio tape, it actually works. It might support the TFCC that's actually injured, but then you might consider rather making the patient a wrist widget. To do your test for the TFCC, say it stays sore there, why? Do the test, and if the TFCC is tender, make a wrist widget, and then with that support of the TFCC, they won't need the K-tape, but then it'll be better support in allowing the TFCC to heal. So I agree. Figure out why they want the tape. Maybe they just think it looks cool.
I see the next question is also then just about the comorbidities, patients with diabetes and RA. So just something, I mean, with diabetes, we're obviously going to be looking at, it's going to be a prolonged wound healing and soft tissue healing process. So you're generally moving a lot slower through the process and just respecting that wound healing. I think also, also understanding that there may be pain with RA as well. So again, I think it's more, a lot of it has to do with the handling principles that you're using and the approach that you're using.
And setting functional goals, because I think often, these patients go from service provider to service provider to get rid of the pain, but in essence, in order to be independent. And I think if we just remember about functional goals and not become too focused on the diagnosis, it's going to give the patients a lot of relief while we're still working on the diagnosis as well. Yeah.
I see so the one here says, I wanted to find out what is the indicator for using a wrist brace post-conservative management, POP for 6 weeks. So I'm assuming then that the patient has been in POP for 6 to 8 weeks, and then whether or not, so what I understand a wrist brace is like an off-the-shelf one that you would buy at the pharmacy with a little metal bar on the inside. So again, I would, if it is 6 to 8 weeks, and if I can, if the patient's been well immobilized, then there shouldn't be a reason that the patient needs any kind of stability. And really what you're wanting to do is try and encourage as much movement as possible, as much confidence as possible. However, if you see that the patient is so fearful to move and they don't even want to let their hand move away from their body because they feel that they can't, if that gives them the confidence to be able to move, having this black brace, this wrist brace, then I would say yes. Let them use it until they develop the confidence to say, okay, well, actually, no, I don't need that.
Then there was a question a little bit earlier. Somebody said, where can we find courses? I see there's SASHT. Yes, SASHT has a lot of courses. And I'd like to recommend a book that helped me a lot. I've got a picture here, the handbook by Ulrich Menin and Karion van Vels. I'm going to show you what it looks like. Can you see it on the screen? So this is a very, it's written by an OT and an orthopedic surgeon. It's a very, very user-friendly book. So whenever there's a new diagnosis you haven't come across, you just go to the right section. They show you pictures of the splints. They give you guidelines in terms of what to look out for. It's a very, very handy book to have on your shelf as a quick reference.
There was a question here about a patient having excessive callus formation and the callus formation causing the wrist block. And the patient didn't show any improvement in therapy. So I think also it's important to recognize your limitations. I think as therapists, we do want to fix everything, but there's sometimes things we cannot fix. So in that case, I would probably say that if the actual callus, if there's excessive callus and that is specifically what's causing the limitation, then that might need surgical intervention. So in which case you're just going to need to have an open communication with the doctor. But so again, if you've reached that plateau, you'll need to evaluate, is continuing therapy actually beneficial for the patient?
There's one question that was sent in before that links up with that. The question was, if the RF limits mobility, when should OT stop mobilizing to focus on functional adaptations? An RF should never limit mobility. So the position of the plate or screw should never cross a joint. So that should not be the reason mobility is limited. But a good guide where is to stop with therapy is compared to the contralateral side, and also measure the range at the initial session and again at the end of the session. So if you've reached your 8 to 12 week mark and you're really focusing on the final stages of mobilizing, and you measure the beginning of the session, you do therapy treatment, you measure afterwards, and you still see a 5 or 7 degree progress, you know that the patient still has potential to improve. And they need to come back with higher scores the next week. But if you don't see much of a difference between the end of the beginning of the session, then you know that they've actually reached their plateau, and it's not necessarily due to the RF. It might just be the maximum that they're going to reach because of an intra-articular fracture or whatever the reason may be.
Thank you so much, Adele and Leanne. Okay. Sorry, I wanted to get you guys out of the hot seat and maybe close off. So just a reminder to complete the questionnaire when you leave. Our next webinar is on the 3rd of September, how to manage extension tendon injuries. And you can find the sign-up link on social media, or if you are part of our mailing list, or contact us at the information provided on the slide now. So yeah, thanks again for sharing. Your presentations were amazing. I think we'll all use a lot of your activity ideas going forward. And thanks everybody for engaging in the chat as well. So I think we can close it off there if that's okay.
Thanks for having us. It was a privilege, and yeah, well done to all the ITs.
Thank you, everybody, and have a good night.